We'll wait another 2 minutes.
Hi, Dr. Donovan. I'm Lena, one of the medical students who is helping with the conference. And previously, we have a list of questions that people have submitted before the conference. So I'm recording now so we can share it after. And I'll also have a Google question form for anyone who currently has any questions to enter, and it goes directly into the form that we have.
Sounds good. Thanks, Lena. So I'll start in a few minutes with a brief presentation. We'll wait another 1 minute. I think for some people, the transfer of room step may be tricky. And Lena, can you tell me if I can be seen and heard, or heard mainly on my slides can be seen?
Yes, we can see you and hear you, and we can also see the slides.
Great. All right, so welcome everybody. I'm Dr. Jeff Donovan. I'm a dermatologist and I specialize in hair loss. I'm located in Whistler, Canada. And a very large proportion of my patients in my practice are those with scarring alopecia. And today I've been asked to speak about discoid lupus, pseudopelade, folliculitis decalvans, dissecting cellulitis, acne keloidalis, and erosive pustular dermatosis. And so I will set out to indeed do that, and then we'll have time for questions. So I'd really like you to have some insight and understanding into these conditions. These are conditions for which we're learning a lot more about, and they are conditions that we're improving treatment options for patients. So that is certainly really good news. These are scarring alopecias.
Mr. Donovan, I'm struggling with hearing your voice. Can you please little bit increase your mic? That will be great.
Great. How's this?
Amazing. Thank you so much. Thank you.
Great. Let me go back. This. So these are scarring alopecias we're talking about. And on the right side of the screen, we see some scarring alopecias. These are conditions where the follicular openings are often scarred over in the later stages of the disease. You can see on the left, we have some non-scarring hair conditions where we can see these follicular openings or these dots. In the right-hand side, these are missing. And those are typical of all the scarring alopecias in the later stages, whether you're talking about FFA or LPP or discoid lupus or pseudopelade, they all look the same in the end stages. But in the early stages, they look different, and that's what we're going to talk about today. So what's similar between these scarring alopecias we're talking about today? Well, not everyone's itching, but some people are itchy. Not everyone has burning, but some patients have burning. Not everyone has tenderness, not everyone has shedding. So these are symptoms that are common, but not everybody has these. But what is common is the perception that hair is being lost. And all of these scarring alopecias have the potential to lose hair. And the other thing that's common is what's actually happening under the microscope. So even though these 6 conditions that I'll speak about today are different, they all cause inflammation around the hair follicle. And this is a cartoon of a hair follicle. This is a person with orange colored hair. This is the surface of the skin. And this is what we call the oil gland. And these little yellow dots are what we call stem cells. And stem cells live about 2 or 3 millimeters under your scalp. And so if you touch your surface of your scalp, about 2 or 3 millimeters under there are millions and millions of stem cells that potentially can make new hairs. But what happens in scarring alopecias is there's inflammation. And the inflammation isn't located just anywhere. The inflammation is located around these stem cells. And we don't understand fully why, but we know that in these scarring alopecias, the stem cells can be destroyed. And when you lose these yellow dots or these stem cells, you lose the ability to make a new hair. And that's why scarring alopecias can be permanent sometimes. But if we catch it in the early stages and we tell this inflammation to go away, we can sometimes save some of these yellow dots, save some of these stem cells, and we can sometimes get some hair. Now, some of you may have had biopsies. Biopsies are not required in every single patient, but sometimes we do require biopsies to 100% confirm the diagnosis. And this is a little biopsy punch tool. This is the surface of the scalp. This is a finger. And the biopsy size that's typically used is 4 millimeters. So about the size of a pencil eraser. That's how big this dimension is here, 4 millimeters. And we do biopsies often because we want to know the inflammation that's present in the skin. What type of inflammation is present? Because the type of inflammation is very, very helpful to determine what category of scarring alopecia it is. And if the pathologist or the doctor looking at the slides under the microscope sees a lot of inflammatory cells called lymphocytes, we categorize it as a lymphocytic scarring alopecia. If the pathologist sees a lot of neutrophils or infection-fighting cells, they may classify it as a neutrophilic scarring alopecia. And if there's lots of different types of inflammatory cells, we may categorize it as a mixed scarring alopecia. And so today we're going to be talking about 2 conditions in each of these groups. We're going to be talking about discoid lupus and pseudopelade. We're going to be talking about folliculitis decalvans and dissecting cellulitis. And we're going to be talking about acne keloidalis and erosive pustular dermatosis. So 2 examples from each of these 3 groups. So let's begin by talking about discoid lupus. Discoid lupus is a condition which even the name itself invokes some sort of a worry that perhaps this is related to a condition called lupus, which is a full body condition which can affect the heart and lungs and kidneys and many parts of the body. Fortunately, patients with discoid lupus, the scarring alopecia affecting the scalp, very rarely develop lupus of the body. It's something that we monitor, but it's something that is very uncommon, fortunately. But discoid lupus can affect the scalp and it can affect the skin. I see many patients with discoid lupus because the scalp is often the very first site that becomes involved when this autoimmune disease affects the body. And patients may get red, itchy bumps, and they may wonder if they have a folliculitis of some sort. Is it a shampoo they're using? Is it something, the sweat of the summer? Why am I getting these itchy bumps? And that's very common to many of these scarring alopecias. Many of them start out with red, itchy bumps. Lichen planopilaris starts out with red, itchy bumps sometimes. Folliculitis decalvans starts out with red, itchy bumps. And that's just an indication of the hair follicle being inflamed. But what happens over time is the hair follicles become plugged with materials, as we'll see in a minute, and you get loss of pigment. And about 5% of patients will develop this condition, systemic lupus. So this is an example of a patient with discoid lupus. It is a scarring alopecia where you get changes in pigment. You get darker areas and you get lighter areas. And this is another example, and you can see the light and the dark areas is very similar. It may affect the inner parts of the ear as well, can affect the skin of the face, can affect many parts of the body in some cases. When you look up close, really, really magnified, this is what you see. You see hair follicle openings that are plugged with a material called keratin. And you also see hair follicle openings that are plugged with blood. And so some of them are red, some of them are yellow, depending if they're plugged with keratin or blood. And so when I see this picture, I have immediately a tip-off that, wow, look at the red dots, look at the yellow dots. This may be discoid lupus. Here's another picture of discoid lupus. You can see the red dots. Here's some follicles that are plugged. And there's scale around the hairs. And this scale around the hairs is very similar to what we see in lichen planopilaris. So some patients with lichen planopilaris that I see in the clinic enter the office with a diagnosis of lichen planopilaris from another doctor, but they leave the visit with me with another diagnosis like discoid lupus, because sometimes discoid lupus mimics lichen planopilaris. And if you were to just show this hair to a dermatologist, it wouldn't be a bad idea to conclude this looks like lichen planopilaris, another scarring alopecia. But the red dots, the plugging, and the pigment changes, the dark brown in some areas, is a tip-off that this is discoid lupus. And so the scale around the hairs very much resembles lichen planopilaris, but you can see the dark pigmentation, and some of the follicles are actually becoming just a little bit more plugged than we see in lichen planopilaris. So 5% of people go on to develop systemic lupus, which is an autoimmune disease. Who are the individuals that are more likely to go on to develop systemic lupus of the body? Well, a nice study this year by Fredu showed that patients under the age of 25, patients with darker skin types, and patients with a blood test showing a positive ANA test are more likely to go on to develop lupus, especially when you have all three of those. So those are helpful pieces of information, and doctors will see patients back every 3 months, 6 months, 1 year, and they will check to see if there's any evidence if a patient is developing systemic lupus. So how do we treat discoid lupus? Well, there's about 12 or 15 treatments for discoid lupus, and we categorize them into first-line treatments, second-line treatments, and third-line treatments. In other words, treatments that we choose first, treatments that we choose second, and treatments that we choose third. And when we're deciding on treatments, we decide 4 things. What is safe? What is affordable? What is easy to do? And what is effective? You might think to yourself, well, you should just choose something that works. We want this condition to stop. But if something is highly effective, but very, very expensive, and not safe at all, then that's not a good option. So we constantly evaluate all 4 of these categories. And we like something that's pretty safe, pretty affordable, easy to use, and highly effective. That's the ideal treatment option. And so for discoid lupus, the things we use first are topical steroid lotions like clobetasol, steroid injections like triamcinolone or Kenalog. We use topical tacrolimus, also known as the trade name Protopic. Hydroxychloroquine is a very important option for discoid lupus, sometimes known by the trade name Plaquenil. And these patients have photosensitivity, so we often encourage sunscreens. So these are the first-line options, the ones we reach for first, but you can see there's many other medications we use if those ones aren't working. So let's talk about pseudopelade for a moment. Pseudopelade is another scarring alopecia that's very closely related to lichen planopilaris. One of the differences between pseudopelade and LPP is it's less red, less scaly, and we see these indentations in the scalp, which I'll explain in a minute. So this patient has pseudopelade, often affects the central scalp. And if you were to put your finger here, you would see that it dips down. It dips down. We call that atrophy. And so this is the normal surface of the scalp, a cartoon. And what happens in pseudopelade is you often get indentations. And these are the same type of indentations that some patients see when they get steroid injections. And so when you see a patient with pseudopelade and you put your finger here, your feeling is, wow, it dips down. I wonder if this patient had steroid injections, and that's the reason it dips down. Well, the disease itself sometimes causes these indentations. But you can see that it's not very red, it's not very inflamed. And so sometimes the mistake that doctors make is when they see a patient with pseudopelade, their feeling is, oh, it doesn't look like you need treatment. It looks pretty quiet to me. No redness, no scale. I don't think you need any treatment. Meanwhile, the patient goes on to lose hair if they don't begin treatment. So pseudopelade can fool you because it looks very quiet. Sometimes it has large areas of hair loss, but sometimes it has just tiny areas of hair loss, like shown here. Here's a nice example of pseudopelade where you can see we don't have scale around the hairs like we saw with discoid lupus. It looks pretty clear. This hair here is twisting, which is a very common feature of scarring alopecia called pili torti, but it doesn't look very inflamed. And so you would think that this is no longer active. I think the patient's treatments must have all worked successfully, but that's very typical of pseudopelade. It looks quieter sometimes than it is. And the treatments for pseudopelade are very similar to lichen planopilaris, where we'll use topical steroids, steroid injections, doxycycline, an antibiotic, and sometimes hydroxychloroquine. Let's talk about folliculitis decalvans for a minute. Decalvans means to scar, and so it's a folliculitis that scars. And of this neutrophilic category, of which folliculitis decalvans and dissecting cellulitis belong, it's the more common one. It often affects the top of the scalp, and patients have itching and burning, and they often have discharge of pus or bleeding. And some patients will wake up with blood on the pillow. And in fact, sometimes in really challenging diagnoses, I will ask patients, do you ever wake up with blood on your pillow? And sometimes the patient will say, yes, I do, absolutely. And that's a very important tip-off that this could be folliculitis decalvans. So patients have pustules or little pus-filled openings. They may have crusting, they may have fusion of hair follicles, which we call tufting, which we'll see an example in just one moment. And when you take a swab to the scalp or a little Q-tip and send it off to the lab, you often grow a bacteria called Staph aureus. And so this is one of the scarring alopecias associated with infection. So here's a very typical example of folliculitis decalvans where you see scarring. Oops, you see scarring. This area is quite white. And you see these reddish, crusted, yellowy areas. And these are the inflammatory response to the hair follicle. And when you look up even closer, you see that some of the hairs are grouped together. And we'll see another example here. This is an up-close example of folliculitis decalvans. Normally, hairs come out of the scalp in either by themselves or in groups of 2, or sometimes 3. That's usually all that happens on the scalp. But here you see the hairs are coming out in a massive group of about 15 or 20 hairs. That's what we call compounding. And you can see the crust, and you can see the bleeding. And so this is very typical of folliculitis decalvans. In lichen planopilaris, we don't usually see the compounding as frequently. This is a classic example of lichen planopilaris, or LPP, where we have hairs that are coming out with scale around them, but they often come out just by themselves. In folliculitis decalvans, or FD, the hairs are coming out in groups of 5, 10, 11, 12, 13, 20. Here's a very subtle example of a patient that was thought to have dandruff. And you can see here that this hair here is coming out in groups of about 7 or 8. And so that's a tip-off here that, oh, this isn't normal. The maximum hairs generally come out is 4, but usually it's 1 or 2 or 3. So this is abnormal. And this is a patient with folliculitis decalvans. This is also another fused hair follicle where we have 1, 2, 3, 4, 5, 6, 7, at least 7 hairs. So folliculitis decalvans is associated with bacteria, so we often use antibiotics, either topical or oral. And sometimes we use isotretinoin, which is sometimes known by one of the brand names, which is Accutane, but there are many others. And Accutane affects the keratinization of the hair follicle and how hospitable it is to growing bacteria. But there's many treatments for folliculitis decalvans, but often we begin treatment by trying to stop inflammation and trying to eradicate bacteria. So let's talk about dissecting cellulitis for a minute. Dissecting cellulitis is one of the scarring alopecias, which is particularly common in young patients. Young Black and Hispanic men are a fairly common group that is affected by dissecting cellulitis. Patients have itching and burning and pain, but they have discharge. They have pus and fluid that comes out of the scalp, and it can be quite debilitating for patients because of the drainage that's constantly occurring from the scalp. The scalp is wet, hats become wet. And it often affects the top and the back of the scalp, and we'll see an example in a minute. Some patients not only have the scalp affected, but they have the underarms affected and the groin area affected. We call that hidradenitis. They have the buttocks area affected, called pilonidal cysts, and they have a very severe acne affecting the back and sometimes other areas, called acne conglobata. And so it can be a very debilitating condition. Here's a patient with dissecting cellulitis, where we can see pus coming out. If you were to press here, you would feel that it's like a sponge. It's quite boggy. And sometimes in the very early stages of dissecting cellulitis, it looks very similar to alopecia areata, an autoimmune condition. So this man has early dissecting cellulitis with these circular areas of hair loss. This patient has alopecia areata with circular areas of hair loss. And so sometimes it is mistaken in the early stages. But what you can see here is one of these sinus tracts, or these tunnels. These tunnels are really important features of dissecting cellulitis. And when you look up close, you see what's called cribriform scarring. This scar in sort of a circular, almost bubble-like pattern. And this has often been likened to a Middle Eastern pancake. And so you can see the resemblance here to the resemblance here. And that's a really helpful feature of dissecting cellulitis. How do we treat dissecting cellulitis? Well, the first line treatment is with isotretinoin or Accutane, or the other trade names that are available. And sometimes we use antibiotics. But generally, this condition, even though it has pus and drainage, it doesn't tend to grow organisms the same as other conditions. Dissecting cellulitis is one of those conditions where if we treat it early enough, we can actually regrow hair. And so it's important in any of the scarring alopecias not to have the view that these hair loss conditions are 100% permanent. That is a myth. Sometimes if you catch it early enough, you can get some improvement. Some scarring alopecias are more likely to improve a bit. Dissecting cellulitis is famous for major improvements if you catch it extremely early. So let's talk about acne keloidalis, which is one of these mixed scarring alopecias. In other words, when you look under the microscope, you see a variety of inflammatory cells. So acne keloidalis can affect males and females, but it commonly affects the back of the scalp, especially in those with curlier hair types. You can see these papules on the back. This is the ear. This is the neckline. An individual with darker colored skin and an individual with lighter colored skin. Sometimes this can become quite thick and all these little bumps join together and you can get quite a plaque or raised area of scar tissue. The risk factors for acne keloidalis are being male, being of African descent, having metabolic syndrome, so diabetes, high blood pressure, obesity, having a chronic folliculitis, having curly hair types that also cause ingrown hairs on the beard, and having high blood pressure. Acne keloidalis nuchae is a condition that is partly due to the hair follicle being so curly and going back into the skin in order to form an inflammatory reaction. One of the ways that we treat it is with topical antibiotics, topical vitamin A derivatives, anti-inflammatory agents, and antibacterial agents. And sometimes we do use oral antibiotics and oral isotretinoin. And sometimes we inject steroids to calm down the inflammation. When the condition is quiet, no longer spreading, no longer causing an issue, sometimes these little bumps can be surgically removed. Erosive pustular dermatosis of the scalp is the last condition that I'll mention just briefly. It's a scarring alopecia that often affects individuals in the 50s, 60s, 70s, and 80s years, and patients have crusts and erosions on the scalp. But what's so remarkable about erosive pustular dermatosis is that within a month or two of clobetasol, a topical steroid, this can be almost gone. We don't fully understand what causes erosive pustular dermatosis, but we think that trauma to the scalp or injury to the scalp, ultraviolet radiation injury, for example, over long terms, can cause this condition to come out. And we treat it with topical steroids and sometimes topical non-steroids like tacrolimus. So the conclusion for this talk today is that we classify scarring alopecias in three groups: the lymphocytic group, the neutrophilic group, and a mixed group, depending on what the pathologist sees under the microscope. Now, we don't always need a biopsy and we don't always need to send it off to the pathologist to look under the microscope. Sometimes you'll see a patient with dissecting cellulitis, and as soon as you walk in the room, you know it's dissecting cellulitis. You'll see a patient with folliculitis decalvans, and you know it's folliculitis decalvans. So we don't always do biopsies. Some patients will ask me, I haven't had a biopsy. Should I have a biopsy? The answer is, if your treating physician is confident that this is what the diagnosis is, then a biopsy is not needed. These scarring alopecias may look different when you look at them from the surface, but they share in common a destruction of these stem cells or these little yellow dots that I showed you in the cartoon. And the treatments may be different depending on which type we're talking about, but they share in common a reduction of inflammation. And once we can chase the inflammation out of the hair follicle, we increase our chances that we'll put the disease to sleep or just to rest. So I think that is where I end. I look forward to any questions that you have about anything whatsoever, but I thank you so much for listening today.
Uh,
Dr. Donovan, oh, sorry.
please go ahead. Please go ahead.
No, go ahead. Go ahead.
Okay. Mr. Donovan, thank you for the presentation. I have scarring alopecia on my wife's scalp, and one of the doctors, especially my wife's dad, is a well-known micro surgeon in Turkey. And he's used to cut the skin parts, etc., etc. And one of the dermatologists told us there is a scary alopecia in the forehead, but like two fingers large. It's not very big, but it's like two finger size big. And he and she recommended us to cut that piece and stitch the next two pieces so we can improve the hair condition over there. Do you think, and I was a little bit conservative about that because on the contrary of my father-in-law, I'm not, very likely to go directly with a surgery operation. And I would like to ask you first, should it be one of the first most effective solution to this problem, or is it a solution, or what is your recommendation there? Because we already put some steps like getting minoxidil, or we're putting some cream with cortisone right now, but we didn't have enough progress. So can it be a solution to jump, or should we a little bit more patient? What is your recommendation here?
Great. So thank you for this question. The first thing I'll say is that I would need to see the patient's pictures. I would need to know more about the story. But there's a very important rule in most scarring alopecias, and that is cutting is rarely a good option until the condition is quiet. The second principle is that we absolutely need a diagnosis. And so this must have a name. There are 10 or 11 common scarring alopecias, which we call the primary scarring alopecias, but then there's another 30 or 40 secondary scarring alopecias. So there's 50 types of scarring alopecia. We absolutely need a name. Certainly when I hear you say, finger breadths, forehead, things like that, there are things that come to mind, but without pictures, it's difficult. But things like morphia and a condition called en coupe de Saab and other conditions are possible. But the principle is it does not matter to me what the name is right now, because no matter what it is, until the condition is sleeping, cutting is rarely a good idea, because that increases the chance of it becoming even more active. And so we really need a diagnosis. And for many of these scarring alopecias that are of the qualities that you've described in the brief information that you've given, we sometimes need systemic or tablet forms of treatment. Sometimes we can use ultraviolet, narrowband UVB and UVA as well, depending on the type. So we can use ultraviolet radiation. But it's critical that a diagnosis be given, and cutting it out at this stage when it's still active, still progressing, is usually not a good idea.
Okay, well noted. Fortunately, she's also in Canada. She's living in Canada, so we're also considering to visit you in Whistler, or maybe a remote consultancy. So you might hear further from our side. Thank you so much for your answer.
Thank you.
Hello, Dr. Donovan. Thank you for your presentation. I do have a question. In your years of practice and expertise, how typically have you seen females diagnosed with AKN? I was recently diagnosed with that, and
Yeah.
I'm having like a hard time accepting that diagnosis since it's typically found in males. So I
Yeah.
just wanted to know what your take on
It,
that.
yeah, we do see it a lot more commonly in women than the textbooks would lead you to believe. And so that's really an important principle. There may be certain parts of the world, so certain backgrounds, where acne keloidalis nuclei is even more common. Women in Brazil and some parts of South America are much more likely to experience acne keloidalis than women of Northern European descent. So there are pockets in the world where acne keloidalis is much more common in women. And so I do think for acne keloidalis, our textbooks and a lot of our online information is a little bit biased towards the male, and it makes it frustrating for patients, but we absolutely do see acne keloidalis in females.
Okay, and sorry, just one more. Does it typically have a burnout phase, or would I have to be on treatment forever?
So for all of the scarring alopecias, there are groups of patients, and it's true for almost all of the scarring alopecias. There are some patients that, for some reason, have the inflammation for 6, 9 months, a year or two, and then it goes away. Then there are patients that have scarring alopecia requiring treatment for, several years, 3, 4, 5, 6, and treatment keeps it quiet. And then eventually it does go to sleep and treatments can be slowly reduced and stopped. And then there are patients for which it does grumble on, it does continue on despite treatments. And treatments may help slow it down, and treatments may help put the brakes on it to some degree. But all three of these scenarios exist for all the scarring alopecias. And I think there's a lot of myth in the scarring alopecia world, some permeated by misinformation online, but there's a perceived notion that these scarring alopecias last a year or two and they go to sleep. Why do I know that? Because patients come in and say that they've learned this information online consistently. So this is accurate for a small proportion of people. Some patients it's a little longer, and in some patients it's even longer. As we get better and better at treating scarring alopecia, this is changing, and so some patients do have success. But when you are first diagnosed with scarring alopecia, it's hard to know if you will be in the first category or the second category or the third category. But you'll quickly come to find out which one it is over the first 6 or 9 months of treatment. If your redness or itching, decreases quite a bit with treatment, if the number of new bumps or new areas seems to diminish, you used to get 2 spots a month or 2 bumps a month, and now it's 1 bump every 2 months. Well, that means you're winning. And all those things are really good signs. And so as time goes on, you'll come to understand what type you have. Do you have an easier to treat kind, or do you have a more stubborn kind? So it's hard to predict on day one, but I must say, having treated large numbers of patients with scarring alopecia, that we achieve success a large proportion of the time, and much larger, much more frequently than I really imagined when I started out as a physician treating hair loss. So we can get the condition quiet in a good proportion of patients, but not every single patient.
Okay, thank you, Dr. Donovan.
Thank you.
Can I ask a question? This is Sylvia. I had a diagnosis for Graham-Little syndrome
Mhm.
that I was given when I lived in the States, and I've now moved to Canada. I have not been able to find healthcare here yet. But at the time I got my diagnosis, I had other things going on, and it seemed like lower priority. But now I'm looking at it like, okay, this is a longer term prospect. I've been treating it with topical steroid when things are particularly inflamed. But I would just like a little bit of information about the condition in general, and whether I should be, pursuing a more active engagement with the condition.
Yeah. So Graham-Little is really a type of lichen planopilaris. And so all of the principles that surround lichen planopilaris apply to Graham-Little, including the treatments. And so Graham-Little is a condition whereby there is a scarring alopecia on the scalp, which very closely mimics what lichen planopilaris looks like. There can be loss of eyebrows and eyelashes, underarm hair, and other parts of the body. And there can also be these bumps or itchy follicles on the abdomen, sometimes on the arms, which is often misdiagnosed as keratosis pilaris. And so the treatments that we have for lichen planopilaris are useful in Graham-Little because Graham-Little is lichen planopilaris. It is a type of lichen planopilaris. And so, many physicians that train with us say, what is the treatment protocol for Graham-Little? And it's quite identical to lichen planopilaris. The decision on whether we should use treatment or not really depends on, is there hair loss progressing? Does the scalp look different than 6 months ago, or does it look the same as 6 months ago? Does it look the same as a year ago? What about the eyebrows? What about the eyelashes? Are there bumps on the abdomen? Are there bumps on the arms that are problematic? And then it comes down to the patient. Some patients will, with Graham-Little, will say to me, I've had Graham-Little for a long time. It's a little active in my scalp, but not super active. What I really would like help with is keeping my eyebrows and eyelashes, or helping with these itchy papules on the abdomen. Can we try to make those go away? Because I don't want those red bumps on my abdomen. So it really comes down to the patient's goals. Some patients will say, for example, the goal is to preserve scalp hair and keep scalp hair, preserve eyebrow hair. But the patient may say, you know what, the bumps on the arms and the abdomen is not too bad. I don't want to focus on that right now. I understand that the hair under the arms or in the groin is more difficult to come back. So doctor, let's not focus on that. Let's just focus on my scalp hair and my eyebrow hair. And so great, we may start with topical steroids in the scalp like clobetasol. We may use hydroxychloroquine, we may use doxycycline, and we may use steroid injections. So those are very common treatments for scalp Graham-Little. For the eyebrow, steroid injections may sometimes be used, topical steroids, but we're much more careful using topical steroids around the eye. So we may use topical non-steroids, which go by names like tacrolimus and pimecrolimus, which are sold under the names Protopic and Elidil. And so these are either an ointment or a cream, which can help reduce inflammation. And sometimes when things seem to be calming down a bit, the redness is going away, the itching is going away, we may even add minoxidil to try to stimulate some growth in the hairs. So the decision on treatment is really personal one, and it's helpful to meet with the dermatologist to discuss your full story, and to understand all of the treatments and these tiers of treatments. And so the first line treatments tend to be fairly well tolerated, often covered by insurance if you have private insurance. Often, if one doesn't have private insurance, are sometimes costly, but not exorbitantly costly. And then as you move into second line and third line treatments, we come to treatments that may have more side effects, or maybe more costly, or we just don't have enough research. But there's a large number of treatments available for each of these scarring alopecias, including Graham-Little. And it just really comes down to the patient's goal. You want to take pictures, and as you're waiting for, to see a physician, you want to take pictures, because that's so helpful to say to your dermatologist, listen, this is what my scalp looked like on December 8th, 2023. This is what my eyebrows looked like. This is what my arm looked like, and any other part you want to take. And then you may take a picture 4 or 6 months later and say, this is what it looked like 6 months later. And if when you look at those pictures, the feeling is, it looks the same, well, that's good news, because it means that it's relatively stable. If over those 6 months it's gotten worse, then that's helpful as well, because it tells us that this is active. We need to be a little bit more aggressive with the treatment if the patient so agrees. And so I certainly would encourage everyone to take pictures, but especially in a situation like this where you're waiting, it's so helpful to have those pictures, because that really will guide the treatment. So as you're looking for Graham-Little treatments, you really want to focus on the lichen planopilaris treatments. There, of course, are many papers written on Graham-Little, but
okay, thank you, Doc.
They're the LPP. Yep.
The other thing I wanted to ask was, because it is so, it's not focused just on the scalp. And so a lot of the treatments about topical steroid, I guess I was concerned about just such broad application. And that's really been my concern in, how much steroid can you put on your body if you have an outbreak that is, broader.
Yeah. So if you're guided by a dermatologist who's very experienced and it's short-term, the answer is a lot. It must be short-term, it must be short duration, and it must be monitored. But you're absolutely right that as soon as you start applying steroids more broadly, you immediately present some caution. Topical steroids used without monitoring, without proper amounts, can lead to absorption into the body, can lead to thinning of the skin, and can lead to a lot of side effects. So typically in Graham-Little, we're not putting topical steroids all over the body. We're putting topical steroids on the scalp, perhaps a small amount to an eyebrow, an occasional amount to a localized area, perhaps on the abdomen or on the arm. And that's about it. If the feeling is that the inflammation is widespread, like the legs, like the arms, like the body, and more widespread, topical steroids is not the way to go. That systemic agents like hydroxychloroquine, doxycycline, methotrexate, cyclosporin, and mycophenolate, these are the ways to go to address the inflammation.
Okay, thank you.
Thank you.
Well, since nobody else is popping up, I've got one more question. And that is, as I said, I've just recently moved to BC. I can't get in through the primary system. As you know, there's difficulties there. Is it appropriate for me to talk to your office directly? Or do I need to go through a walk-in?
You certainly could. I'm no longer accepting referrals at the present time because our wait list is so long. But I would certainly invite you to reach out to my office and just introduce yourself, and they may be able to assist and let them know your connection through SAF. But I just let you know when you contact them, you will be told that I'm not accepting patients.
That's been my general experience so far. So trying to find a way into the system. I can only find dermatologists that work here in Victoria on a cosmetic basis. So yeah.
Gotcha. Yeah. So you may want to, you could contact my office, number one. Number two, you could get a referral to a dermatologist in the mainland.
Okay.
And so that's an option. But you would need a referral from your general practitioner to see a dermatologist.
Thank you.
Thank you.
Dr. Donovan, I have another question.
Yes, please.
In the beginning of this disease, my wife had a very small, tiny patch, and we applied some cortisone directly. We injected some cortisone by a recommendation of a dermatologist. But that time we were in Dubai. And then we saw that there was a small, broadening, a dark line coming to the forehead. But then it stopped moving, it stopped advancing to her nose. But then the hair loss started to be accelerated. So in this sense, the first dermatologist we saw after this dermatologist who applied the cortisone, she said, this is coupe de sabre, which also you mentioned. But then now they think that it's not a coupe de sabre, because coupe de sabre also has a progress to the backhand of the scalp, but it stopped, as I told you, like just 2 finger large, and it stopped there. So now they are focusing more on discoid lupus. So, but my question is this typical scarring alopecia variation, or changes its typical like types? Like it starts with inflammation or alopecia areata, then it turns to scarring alopecia, but a different type, then a different type, or because we couldn't have one concrete diagnose right now. Even we tried biopsy, even we tried, we saw different dermatologists. This is how we are struggling with. But is there any chance about this, like, different types in one patient?
Yes, it's such a good question. And some of the scarring alopecias are pretty similar on the skin, on the scalp, on the cheek, on the chin. It all looks the same. Other scarring alopecias can look very different, even in the same person. When you move from the chin to the cheek to the eye, discoid lupus is famous for that. It's famous for having all these different types of appearances, or what we call morphologies. And so absolutely it could be. And in a situation like this where the diagnosis is difficult, biopsies are helpful. We always are careful on the face because biopsies leave a small scar, so we're cautious. The thing about a challenging diagnosis like this is sometimes there may be a rash or some sort of inflammatory area hidden in the scalp for which you can take a biopsy, or an inflammatory area on the arm or the shoulder or the hands that you can take a biopsy away from the face. So, a full skin examination is really helpful because sometimes there are clues elsewhere. And in the setting of discoid lupus, some patients will have more than one type of lupus as well. A person can have discoid lupus, and they can have what's called subcutaneous lupus or tumid lupus, or all these other forms of lupus. The blood work can sometimes be helpful as well. It doesn't confirm the diagnosis, but it gives clues. And these are tests like the ANA test and other inflammatory markers. These can all be helpful in terms of getting clues together. And so I can appreciate from the brief information that you've given that this is a challenging diagnosis. Sometimes we do need 2 biopsies. Sometimes we do need to observe how it responds to treatment. Many of these scarring alopecias respond to similar treatments. And so we try hard to get the diagnosis accurately before we start treatment. We do our absolute best. But sometimes if we feel like we're not sure, then sometimes what we do is we start treatment, including things like hydroxychloroquine, things like topical pimecrolimus, topical steroids sometimes. And then we observe what's happening. And sometimes we will go on to stronger and stronger treatments like methotrexate and other immunosuppressants. But we really try hard at each step to get the diagnosis. In the case of discoid lupus and en coupe de Saab, and one is wondering about it, we can't take any more biopsies. Sometimes if it's affecting the forehead, or sometimes we will have imaging done, like an MRI or other ultrasounds, depending on where it is, to ask our radiology colleagues to help us. This is a challenging case, please help us. But I think what's equally important in a challenging situation like this is lots and lots of pictures. So I would certainly encourage you to take lots and lots of pictures. This is what it looked like here. This is what it looked like after treatment. This is what it looked like next. And to be aware of subtle things, the inside of the ears, the top of the hands, the body, the face, what the face does in the summertime in higher ultraviolet radiation. Does it get better? Does it get worse? Is the hair shedding? Is the hair itchy? And all these things are helpful clues to an eventual diagnosis, but it's not always easy.
Okay, but your primary view on this, if discoid lupus is hard to define or hard to catch, or can vary depending on the other type of indicators, but it doesn't change. You mean if it starts as discoid lupus, it continues as discoid lupus?
Yes.
Am I correct? Or
it could change within the lupus family, but it stays as lupus. That's right. That's right. It doesn't become another one, but it can change within the lupus family. There's about 4 or 5 different cousins of lupus that it can move around to depending on the patient.
Okay. Thank you so much. Thank you for your answer.
Thank you.
Thank you so much.
Dr. Donovan, I have a question. In your presentation, you said that dissecting cellulitis, if it's treated early enough, there could be significant improvements. Can that also be the case with AKN? I just want to be realistic. Like, will I get some growth back?
Yes, absolutely. It is possible. And so it depends on the patient, but absolutely. And it just depends on how, the term we use is how aggressive one wants to be. That may be a patient who comes in to see me and we want to do everything we can to stop this. We may consider a course of antibiotics like doxycycline if the patient has no reasons why we can't use this medication. We may use topical steroids on the back with an antibiotic inside the steroid like clindamycin. We might see the patient back every 6 weeks or 8 weeks, and I might inject each of these little bumps with a tiny bit of steroid. I might have the patient wash with certain types of cleansers. I may have the patient avoid all sorts of things that might injure the scalp. So, helmets and hats and, aggressive shampooing. If the male or female has shorter hair at the back, then that needs to be discouraged as well. So we really want to adopt a very gentle hair care routine to acne keloidalis nuchae as well. But absolutely, there are success stories with acne keloidalis. The thing you have to always remember when you look at the internet and look at pictures is the pictures that you always see on the internet are the ones that are more advanced, because it's the easiest to show the condition and what it's all about. But absolutely, there are a lot of success stories. So with acne keloidalis, the principles are avoid injury if you can. Number 2, try to stop inflammation. Topical steroids, steroid injections, try to stop infection if there is any bacterial component that's present, and moisturize. And so many of my patients with acne keloidalis, I will have them use a lotion in the back of the scalp to moisturize and maybe even lift off some of the scale if there's any scale that's developing. So there's a hair care routine that can go along with it as well.
Thank you, Dr. Donovan.
Yeah, thank you. Good luck.
Thank you.
Yes, I have a question.
Please.
My particular type of scarring alopecia, FAPD, has not been addressed. Progression over 50 years. What would you recommend for a current treatment program that's most promising for me?
Yeah. So FAPD is really a combination of androgenetic hair loss and lichen planopilaris. And so when your physicians are thinking about what should we treat, they're thinking about, okay, what do we use for androgenetic hair loss or female thinning? And then they look at the pile of treatments. What do we use for lichen planopilaris? And we try to decide at all times, should we take a treatment out of the androgenetic box of tools for treatment, or should we take it out of the scarring alopecia? Typically, treatments for FAPD include topical minoxidil, oral minoxidil, spironolactone tablets, and sometimes in women that are postmenopausal, finasteride as well. So these are the treatments that can be helpful for the androgenetic component or the female thinning. And that helps stop the thinning. And then for the inflammatory part of the FAPD, the inflammation hiding under the scalp, we commonly will use topical steroids like clobetasol shampoo, and sometimes other inflammatory agents as well. But certainly the topical steroids and the steroid shampoos are at the top of the list. We don't understand everything about FAPD, but what we think is happening is the process of genetic hair loss or female thinning is underway. And so the hair follicle wants to get skinnier and skinnier. And for some reason, the immune system, when it sees that happening, it goes after those hairs and it causes a scarring alopecia. And so in some ways, FAPD is a type of genetic hair loss or thinning that is so common in the population. but it happens to be an autoimmune kind of genetic hair loss or female thinning. And so what we want to do is we want to first and foremost stop the thinning process with minoxidil, spironolactone finasteride, these anti-androgens or minoxidil. And then we want to tell the inflammation to go away. We've stopped the thinning process. There's nothing more for you to go after. And that's where these topical steroids or steroid injections come in. And if that's not working, those treatments that I've just mentioned, that's where we next take out the textbooks for female thinning, and we take out the textbooks for scarring alopecia, and we ask, what's next? What could we use next for female thinning? And what could we use next for scarring alopecia? And sometimes it's a bit of experience or expertise to decide, what's next. But that's the basic approach to FAPD. It's a combination of LPP or lichen planopilaris and androgenetic hair loss. So both of those conditions need to be treated at the same time.
Thank you so much.
Thank you.
Does anyone else in the breakout room have questions for Dr. Donovan before I move on to the questions that were previously submitted? Okay, I'll move on to these questions. Thank you so much, Dr. Donovan, for a really wonderful presentation and for the Q&A. And if you feel like you've addressed any question that I've answered well and don't have much to add, we can skip it and move on to the next question to get to as much as we can. So this first one is a patient with AKN, and they're wondering, can treatment for one subtype of scarring alopecia work on another? And can treatments used for alopecia areata and androgenetic alopecia work on scarring alopecia?
Yeah, and so in the year 2023, there's a lot of overlap between these treatments. For example, topical steroids and steroid injections are used in many of these scarring alopecias. I use steroid injections to treat lichen planopilaris, frontal fibrosing alopecia, discoid lupus, folliculitis decalvans, acne keloidalis. And so there is a lot of overlap between these treatments and the treatments that we use, because in many of these scarring alopecias, we're trying to get rid of inflammation. And so our tools are very similar. In the case of acne keloidalis, steroid injections and topical steroids are often used, and we use those in other conditions. And we sometimes use topical antibiotics, which we also use in folliculitis decalvans as well. And so there is a lot of overlap. The treatments for alopecia areata are, again, treatments that calm down inflammation. And we also borrow them to treat scarring alopecia. And so to treat alopecia areata, I use steroid injections. I use topical steroids. I use minoxidil, oral minoxidil, and sometimes we even use other treatments like methotrexate tablets, JAK inhibitor tablets, and we're increasingly using those in scarring alopecia. So there's a lot of overlap between these treatments at all times. As far as the treatments for male balding go, minoxidil, finasteride, and other treatments, certainly if a person has androgenetic hair loss, those are great options to consider as well. And so if a patient has scarring alopecia and has hereditary hair loss, either male or female hereditary hair loss, we often want to treat that as well, because if we can gain some success in treating the scarring alopecia, and we can gain even more success in the non-scarring alopecia and get hair back, then sometimes the end result is the patient has more hair. And so if a patient has two conditions, we want to think about treating both. If a patient has three conditions, we want to treat three conditions. And it's not uncommon to have three conditions. A person might have a scarring alopecia with genetic hair loss, and they might have dandruff. And so we want to treat the dandruff, we want to treat the scarring alopecia, and we want to treat the hereditary hair loss. Some people have four. They have a telogen effluvium or hair shedding from low iron levels that they're battling, as well as scarring alopecia, as well as genetic hair loss, as well as dandruff. And so it's not uncommon in the clinic to have three conditions, four conditions. And so it really shouldn't come as a surprise. And I often say to physicians that if you go throughout your day and the patients that you see have only one diagnosis, day after day after day, just the only thing you're putting down on the page is one diagnosis, you can be assured that you're missing diagnoses. And so it's pretty common to have several.
Thank you, Dr. Donovan. The next question, they're asking for scarring alopecia, what's the best way to reduce inflammation internally, for example, through diet?
Yeah, it's such a great question. And we don't know. That's the simple answer. There is some research now being done to address this. And it's trickier than we would hope. Of course, there's many people who have very strong opinions about this subject. But the reality is that those strong opinions aren't backed up by science or any studies that have been done. But I am a believer that diet has a role, and I'm really very much in favor of this area of pursuit being continued. There are some patients that really believe that when they have dairy or sugary foods, that their scarring alopecia is worse. And that's a clear theme. It's not everybody. And there are some people that believe that when they have gluten-containing foods, that their scarring alopecia worsens as well. And so these are important pieces of information. I don't have any great research studies that I can say to a patient, look at what this study showed. You must avoid nightshades. You must incorporate, these types of foods in your diet. We don't have that yet. But what we do have is patient's experience. And so when a patient says to me, I'm doing all I can with these treatments you're recommending, and do you think I'm wasting my time if I cut out, high glycemic foods? Well, the answer is I don't think you're wasting your time. I don't know for sure, but I don't think you're wasting your time. What do you think, Doc, if I add anti-inflammatory things to my diet, like turmeric and other things that are anti-inflammatory like this? Do you think I'm just wasting my time? No, I don't. I think that we don't have great evidence, but I think that it's reasonable based on everything that patients share. There are certain pockets of the world where some of these scarring alopecias are much more common, and other pockets of the world where it's less common. And one explanation that we have is the easy explanation. It's genetics. This genetics causes that. This genetics causes that. But the other thing that we tend to forget is that the diets are very, very different in different parts of the world. They're less different now than they used to be 200 years ago, but they're still different. And so does this account for some of these differences that we're seeing? For example, perhaps a different incidence of FFA in India than in the UK or in the United States. We don't know. But I think diet has a role, and it's tough to study. And when you do good studies, generally what you do is you tell the patient to take this tablet, take it every day, and you tell another group, take this tablet, take it every day, and you try to keep everything else the same. And you invite the patient back 3 months or 6 months later. Well, when you do studies in diet, it's really hard. It's very difficult to say, you eat this, food or avoid these foods for 6 months and we'll see you back. It's really difficult. And so the best thing we can do is look at diaries of what people eat and what they log in their diary, and compare at the end of the study how much starchy foods did you have, how much caffeine, how much how much potatoes did you have, how much meat did you have, how much cholesterol containing food did you have. They're very difficult studies to do, but I do think there's a role for diet, and I think that'll be a few years until we're convinced, but I encourage my patients to do their best with a lot of green, yellow, purple, orange fruits and vegetables that are rich in antioxidants. I think this is really a fundamental part of a helpful diet for scarring alopecia.
Thank you, Dr. Donovan. And this question is by a patient who has FD or folliculitis decalvans, and they're asking, does it ever go into complete remission? They have lost all of their hair from the crown forward.
Yeah, it can. Again, it doesn't happen to everybody, but it can. And it's dramatically more likely to go into remission with treatment. And so patients that wait for it to go into remission on its own often find that is less likely to happen. In folliculitis decalvans, the hair often does not grow back, but we can prevent the spread to more and more hairs that are involved. But folliculitis decalvans is one of those conditions where some patients have some pretty nice results, and other patients have continual spreading of the disease, and a decision has to be made if you go on to more and more aggressive type therapies, but some people do have remission.
Sounds great, Dr. Donovan. And this question is by a patient who has discoid lupus erythematosus, and they're asking, how do you manage conditions such as folliculitis decalvans, dissecting cellulitis, or DLE at home alongside any medical treatments? What can be done to help with the symptoms at home or prevent flare-ups?
Yeah, I think that, for all of these conditions, close follow-up with a dermatologist is really helpful. But there are some things at home which can be really helpful. First, all of these conditions can be associated with dandruff and seborrheic dermatitis. And if that is present, then a dandruff shampoo routine, maybe once a week, twice a week, once every 2 weeks, depending on the patient, can be really, really helpful. There are some patients who find that shampooing the hair more often really helps to keep some of the scaling and itching and other factors under control. And so if that is the case, then those are really simple things that can be done in addition to the prescribed medications that are being recommended. Sometimes the dermatologist will recommend some as you need type treatments, and those may be prescription or they may be non-prescription. For some patients, antihistamines, for example, can be used non-prescription to control inflammation. And the other things which are often ignored or forgotten about simply because of time constraints, but can be really helpful for patients, is to continue to incorporate into their activities a plan for exercise, a plan for relaxation, whether that's meditation or mindfulness or other practices, can be immensely helpful for patients with scarring alopecia. And it's an area that I know can be helpful to many patients. It's an area that we don't always incorporate into our recommendations, but it can be really helpful. And so when patients ask me, do you think that these practices would be important for me? The answer is a clear yes. And so those are other things that people can do at home.
Thank you, Dr. Donovan. And this question is by a patient who has AM or alopecia mucinosa, and they're asking, how is it typically diagnosed? Do we know like what can cause it, as well as the most common treatment options that you give for this disorder?
Yeah. So alopecia mucinosa is diagnosed differently in children and in adults, but very often it's diagnosed with a biopsy, where a biopsy will capture the specific features of this particular condition. Alopecia mucinosa is treated with anti-inflammatory agents, often topical steroids, steroid injections, depending on where it is and how involved it is. If it's on the face, there could be a range of treatments that are used. But it's the typical anti-inflammatory type treatments that we use for many of the lymphocytic scarring alopecias can be employed for alopecia mucinosa. And that is one condition which sometimes does respond quite readily to treatment. And periodic follow-up is needed. A very, very small number of patients with alopecia mucinosa can have other associated conditions. And a dermatologist will monitor, but most of the time, topical steroids and other inflammatories can cause these areas to become less inflamed, and sometimes some hair can go back as well.
Thank you. And this is also another patient with alopecia mucinosa, and they're asking, does diet play a role?
Again, we're not sure. We don't think that it has a huge role in the cause. But for alopecia mucinosa, we just don't have enough data, even anecdotally, for the role of diet. And so the short answer is we just don't know yet.
Makes sense. Thank you, Dr. Donovan. And this question is by a patient with Graham-Little syndrome, and they're asking, does it impact other areas of the body, such as circulatory health, like gum disease can?
Yeah, it's a great question. And it certainly is possible. With lichen planus of the scalp, or what we call lichen planopilaris, for which Graham-Little is a subtype, we always want to be on the lookout for the involvement of the gums, the involvement of the nails. And so the short answer is it can. And there's really a spectrum of involvement. There are some patients that have loss of eyebrows, scalp involvement, loss of body hair. And the feeling is this frontal fibrosing alopecia, or should we call it Graham-Little syndrome? And there's really sometimes no perfect answer, because these conditions overlap. And sometimes in the field of hair loss, we want to give people names of conditions. And we have to be open to realize that sometimes there's an overlap. You could call it frontal fibrosing alopecia if you want. You could call it Graham-Little. It's a very similar condition. And that goes for the systemic involvement as well. Some patients will have involvement of gum lichen planus, vaginal lichen planus, nail lichen planus, and other patients won't. And so it really is a spectrum. But I think the thing that is important is that when you're evaluating a patient, or you're a patient being evaluated, you really want to be thinking about all of these issues head to toe. In other words, the scalp, the eyebrows, the eyelashes, the body hair, the underarm hair, pubic hair, the mouth, the teeth. I'll often say to patients with lichen planopilaris, any problems with the teeth? And most of the time, patients will say no. But I'll often leave the conversation as the next time you're at the dentist, I'd like you just to ask the dentist if he or she sees any evidence of oral lichen planus. And so I may check in the mouth as well myself, but I'll plant that seed that, I would like the dentist to be looking for oral lichen planus. And once in a while, we do find it. And even if we don't find it at that visit, sometimes 2 years later, a patient emails us and says, do you know I was at the dentist today and my dentist says I have oral lichen planus? So it's helpful to get that conversation going, even if the patient doesn't have it now. As far as other systemic things, I think it's important to be aware that there may be other issues, high cholesterol, high blood pressure, and other issues which may be linked more commonly, and those also need to be discussed with the patients as well.
Thank you so much, Dr. Donovan, for devoting your time and for a really great presentation and Q&A today. Looks like the breakout rooms will close in 18 seconds. Thank you again. Really appreciate it.
Thanks so much. Thanks, everyone. Bye for now.
Bye. Take care.